And I just want you to go ahead and teach, and you can probably ask her to change the slide when you're ready.
Okay, it's really small. Right, okay. How do I make it bigger? Oh yes, I am making it
All
bigger.
right, so you have the floor there, Namala. Go right ahead, and the students probably could ask questions at the end. All right,
Right,
handing over to you.
yeah, okay. All right, morning everyone. I'm Dr. Halai. Sorry for all of these technical glitches. First time I'm doing this. So, um, so we're gonna do um, some dermatology that you would see in primary care, as well as some dermatology cases you will see in hospital. Um, everybody's hearing me? Okay, next slide. Thank you. Thanks. Okay, next slide, please. All right. Okay, so, right, go back to the previous slide. All right, go back to the next slide. Next slide. Yeah. This is a little bit of a silent thing because you all can't communicate so well, but anyhow. No, slide before that. Yeah. So when we think about taking a dermatology history, we have to think about dermatology as a subspecialty in medicine, right? So in addition to taking history about the presenting complaint, the history of the presenting complaint, you want to know basic things like the past medical history and so on. So for example, if you had let's say a 47-year-old male gentleman who's had a rash for about 6 months, and he's presented with some deterioration of the rash, you would want to ask some pertinent questions, such as clarifying the duration of the condition. What are some of the exacerbating factors? Exacerbating factors for skin conditions can be, for example, is it worse with heat or stress? Is it worse with sunlight? And what are some of the relieving factors? For example, taking a cool shower on a regular basis, taking antihistamines, and so on. Has the patient actually had any previous treatments, and was this the correct treatment or some treatment that could have exacerbated it? Was there previous skin problem? Sometimes patients forget about their infantile or childhood history of eczema and suddenly develop a flare of eczema. And is there a family history? For example, psoriasis, eczema, connective tissue diseases. Those are the things we will be more concerned about. Now, in addition to what I've shown you here, it is also very important to ascertain if there is any history of drug allergy, more so than food allergy, because drug allergies and drugs, as you know, can trigger off a range of skin problems. Now, most importantly, for example, let's say back to our patient who has this widespread rash and really affecting his hands. He has blisters on his hands and he can't work. We have to think about the psychosocial impact of the skin disease. Are people going to look at him in a sort of scorning type of way? Is he going to feel embarrassed? Patients with vitiligo, is that going to affect their marriage prospect? Is he going to have pain and unable to work? So the psychosocial impact of skin disease is extremely important. In fact, some of the quality of life issues that come out with skin disease are similar to those of chronic diseases like diabetes. Next slide. Thank you. So on this slide, what we're seeing is just a broad description of some of the terminology I'd like you to learn and to be aware of when describing skin conditions. So generally, we would describe the distribution of the rash, any other patterns, and then we go in a bit closer, talking about the actual morphology of the lesion or the rash. So a macule is a flat lesion. It is not raised, and it can be scaly or flaky, can have different colors, and a patch is the same thing but often greater than 2 centimeters. So here we see the other thing is a papule, and a papule on the second one down is actually a raised lesion, and that is usually less than 0.5 centimeter. So less than 0.5 centimeter, and a plaque is raised with a flat surface. So papules are quite common, for example, acne, a lot of drug rashes, and plaques are commonly seen in psoriasis or granulomatous condition. So nodules usually are raised and they are greater than 0.5 centimeters. So here we see the 0.5 centimeter coming again. And they can be exophytic, raising above the skin, or endophytic, that is palpable within the skin. And vesicles, well, you could see it has something blue in it. Vesicles are actually fluid-filled lesions. It can be usually some sort of serous exudate. And again, it's less than 0.5 centimeters. Blisters also contain fluid, and they are greater than 0.5 centimeter. Now, is a vesicle the same as a blister? Or is it the same as a cyst? They are different conditions or different skin lesions. Cysts are usually lined by some epithelium, whereas these lesions are not. And whereas a cyst, for example, a pilar cyst or a sebaceous cyst, can persist for several months or years, vesicles and blisters only last for a few days and they usually pop. Further down, we see on the left a fissure. So a fissure is like having a small laceration on the skin. So you get a cut on your skin. And so it's deep and goes straight down from the epidermis deep down into the dermis. And they're often very painful. Erosions are superficial, just involving the epidermis, and ulcerations involve both dermis and dermis. Next slide, please. So it's nice to have a little ways of describing lesions in terms of their patterns. And this really comes across better to the examiner for your OSCEs. So if we think about grouped lesions, so grouped lesions, for example, we have a cluster of vesicles, for example, and grouped lesions you can see in things like herpes simplex virus, chickenpox, they come in clusters as well. Linear lesions, they are in a line, like, for example, shingles or some linear birthmarks. Serpiginous are serpent-like, and they're often found commonly in a lot of edges of inflammatory conditions like psoriasis, lupus, and arcuate. If we were to extend the arc, it would eventually form a very, very large circle, but again, seen in a lot of inflammatory skin diseases. Nummular, the other way of describing this is discoid, where it's circle, but the circle is entirely filled. So we tend to see discoid lesions in things like discoid eczema or plaques that are discoid in shape. Okay, and annular, well, that seems to be relatively self-explanatory because it's ring shape. And a common ring-shaped lesion is ringworm, not due to a worm, it's due to a fungus. Another one is granuloma annulare. And often, for example, plaques of psoriasis, when they do heal, they can look a bit ring-shaped because there is central clearing initially. So most of the activity tends to be at the edges of inflammatory dermatoses. Okay, next slide. Thank you. And so, as I mentioned before, when you're talking about the patient, when you're describing the patient, you're going to say, you're going to use terminology like this patient is lying down or sat down in no obvious distress. He has a bilateral symmetrical generalized rash, or he has a bilateral rash affecting both forearms and so on. So rashes that tend to occur on the flexures, more so eczema on the extensors, more so psoriasis, but the two can have both presentations. Right, is the rash on one hand, is it localized, is it Hello? Can we go back to the previous slide? Next one. Next slide. Okay, thanks very much. All right, so this slide gives a broad description of the types of treatments that is used for skin diseases. Moisturizers, antihistamines, antibiotics, topical preparations, topical corticosteroids, etc. So we have to think about the functionality of the skin and why it's important to use a moisturizers. Moisturizers are useful for inflammatory dermatosis, where there is a lot of desquamation, dryness of the skin. And we know that the skin has naturally a lipid layer in the stratum corneum. And a lot of our drugs that we use on the skin are actually penetrated through this lipid layer. So moisturizing is very important. Um, and so things like eczema moisturize help to repair and rebuild that lipid layer. Antimicrobials, you can use them topically or orally for infections. Antipyretic for things like urticaria, and antipyretic drugs are also supportive treatments for eczema and other inflammatory dermatoses. Soap substitutes are less important generally for a large range of conditions, but again, for eczema or some acne conditions, you would want to use soap substitutes because soaps have sodium lauryl sulfate, which essentially dry the skin out. Topical corticosteroids we use commonly, and I would like you to familiarize yourself with next slide. With this broad classification of topical corticosteroids. So mild, moderate, potent, and super potent. And to familiarize yourself with both the pharmacological and trade names. So mild is like 1% hydrocortisone, and we're talking about cream here, not intravenous preparations, okay? And moderate is like desonide or dermatop. And potent, we can see things like betamethasone valerate or betnovate, cutivate, which is fluticasone, elocon, which is mometazone. And sometimes the potency of these topical steroids can be reduced if they are diluted, for example, to a 1-in-4 preparation. And the super potent topical corticosteroid is Dermavate. And please make a note, it is clobetasol propionate, clobetasol propionate. Okay, now you won't use a very strong steroid in an area of thin skin. So areas of thin skin are like the eyelid skin or like the groin, or sorry, the scrotal skin. So because there are potential side effects of topical corticosteroids. So skin thinning is one that you can get over repeated application over several weeks or months unsupervised, and that can manifest itself with telangiectasia, striae. You can also get hypo or depigmentation, hypertrichosis or increased hair growth. Sometimes you will notice in some individuals who use a lot of bleaching creams that do have topical steroids, you will see that on their face. Um, and if used prolonged, unsupervised, you can get things like Cushing syndrome and so on, and all of the um, systemic features associated with Cushing's disease. And this is because if you apply a topical corticosteroid over inflamed skin, there is some absorption systemically, and that can result in Cushing's disease. Just please be aware that when you apply a topical corticosteroid around the eyelid skin, you can get some percutaneous absorption, and that can be associated with increased intraocular pressure like glaucoma and cataract, for example. Okay, so for those areas of the skin, you would have to think about other treatment options. In areas like the palms and soles, where the skin is the thickest, you would be more inclined on using a more potent or super potent preparation, depending on the response on the patient's age. Okay, next slide, please. So we're going to look at some clinical scenarios here. And I have, when you look at this photograph, you will see a well demarcated annular patch on this patient's forearm. And you can see it's the edges are a little bit raised, and in the center, it's flatter, a little bit clearer. So this is the typical lesion for tinea corporis, or locally known as ringworm, and it's often very, very itchy. And the patient can get this from the environment or an animal. To treat this, you will use a topical antifungal, such as topical terbinafine, which inhibits the growth. Inhibits the growth of the fungus. You can use other fungistatic drugs such as clotrimazole, iconazole, or ketoconazole. Um, so if it doesn't settle with the topical preparations, and you will use this twice daily for at least 4 weeks, or if it's more widespread, you can start with an oral antifungal like oral terbinafine for 2 to 4 weeks. Next slide. So this little boy here, what we're seeing is that if we look at his sort of left temporal area or preauricular area, you're seeing some hypopigmented, well demarcated macular lesions. Okay, I'll tell you they're macular. And they can sometimes be a little bit scaly, and this is called pityriasis versicolor. Versicolor means that it can have various colors. So sometimes it's tan colored, sometimes it's brown, sometimes it's black. It can be lighter color because the yeast, which is Malassezia furfur, Pityrosporum ovale, or Pityrosporum orbiculare, can produce oxalic acid, which causes a little bit of transient depigmentation. But that settles down once you get rid of the yeast, and the yeast is a normal commensal organism. So in certain conditions, they can grow and cause the rash. In patients with seborrheic dermatitis, you can also see pityriasis versicolor, and I'll show you a picture of sebderm later on. To treat this, you can use a topical azole first of all, like clotrimazole, iconazole, and then you can use topical terbinafine. And if it's widespread, you can use things like oral itraconazole. We tend to not use things like oral fluconazole commonly in dermatology first line, though. But just bear in mind that this condition can be recurrent because the organism lives in our body. So, next slide. This is another condition that is called pityriasis. And so if we look here on the cheek, we can see these round hypopigmented patches, but the difference from the first patient is that they are ill-defined. They are ill-defined, the edges, and there is a little bit of erythema that you can see. Now, pityriasis alba is like a mild type of eczema that comes on usually on the face and the forearms in children, and it's more noticeable when they're tanned, like pityriasis versicolor, and it can be mildly itchy. So treatment of this is really using a regular moisturizer, and if that doesn't settle it, you can use a very mild corticosteroid as well, like 1% hydrocortisone, but it does eventually go away. Next slide. So this third condition, so we're seeing 3 conditions whose names begin with pityriasis. A lot of dermatological conditions are named because of how they look rather than to deal with anything about the pathogenesis. But in this slide, we're seeing a somewhat ring-shaped lesion on the trunk, and it does have a raised edge, and the center is darker. And often this lesion would develop a few days or a week or two prior to the onset of the other, which is the small oval scaly patches that we're seeing on the trunk. And this is often thought to be like a fungus or misdiagnosed as a fungus. And then when the patient gets all of this rash, it's a little bit concerning, and then the doctor would refer to dermatology. But this is pityriasis rosea, and it is due to a viral infection And we don't necessarily treat for the virus. It's usually self-limiting, can last up to 3 months, but it is one of those very, very itchy skin conditions. And these oval patches usually have a little collarette of scale around the edges, and they usually occur from the neck downwards to the thigh. So very rarely would it extend out of that. And when it's occurring on the trunk, it can go along the lines of the spine to cause like a Christmas tree appearance. So you can use a topical corticosteroid for this. When we see it in adults, we have to look at the palms and soles, uh, looking for any pigmented macules, because sometimes secondary syphilis can look just like that. And in those patients, you would want to do your HIV and VDRL tests. If it's persisting more than 3 months, then you would want to take a biopsy to make sure it's not things like lupus, etc. Okay, so next slide. This is the condition. Here we're seeing this young female child, and a lot of these slides would actually be patients seen over the years. And the main abnormality here is that large area where there is hair loss affecting the parieto-occipital scalp, and you can see that the hairline is actually lost. Okay. When you look closer at the scalp area, there is no inflammation, there's no scaling, but the scalp appears smooth and there are one or two hair follicles. If you were to examine even closer, you can see some of the hair follicles looking like little exclamation marks. The child might also have some round patches elsewhere. And you would have to check on the other area hair-bearing skin, like the eyebrows and the eyelashes. So this is alopecia areata. When it's involving the occipital hairline, we call it the oophiasic pattern. That's oophiasic, and that has less chance of regrowth. Most often, it just grows back spontaneously, but you can use a topical corticosteroid or intralesional steroid in an older child or an adult to stimulate some sort of regrowth. Other things, immunoreactants or irritants can be used like dithranol, diphencypran, and more recently we have the JAK kinase inhibitor, which is a biologic drug. But this drug you would need to use for prolonged periods because whatever you gain, it tends to drop off. So this is alopecia areata. When it's involving the whole scalp, we call it alopecia totalis. When it's involving the whole body, we call it alopecia universalis. Okay. Next slide. And in this gentleman here, we're seeing that in addition to his salt and pepper, sort of black and gray hair, there are round patches where the hair itself, the hair follicle itself, is white. Okay, and sometimes we can see this as a sequelae of alopecia areata. When the hair is growing back, it can be a little bit more fine, more downy, white, or more blonde, but the color does eventually come back. Now, the patients might ask if they can dye their hair, if they dislike the appearance, and yes, that's fine, they can dye the hair. If you notice, though, that the patient has lost the pigments in the skin, for example, if the skin is completely milky white along with the white hair, then it's probably not post-alopecia areata, it's probably just due to vitiligo, and you would look for signs for vitiligo elsewhere. Okay, next slide. Thanks. So the difference here, again, showing the skin condition on the scalp, we can see it is well demarcated. So this large patch and a smaller patch just inferior to it on the parieto-occipital scalp. And there's a lot of scaling in it, and it's a young person. So this is usually what tinea capitis looks like. Again, this is a common fungal infection that is contagious in children. So it can be itchy, usually associated with an occipital lymph node. Sometimes you can get a boggy mass called a carrion, which looks like a big abscess, but it's not primarily bacterial. You have to treat for the fungus. And to treat for the fungus, historically we use griseofulvin at a dose of 10 to 15 milligram per kilogram per day for 6 to 8 weeks. And second line, we used oral terbinafine, 2 to 4 weeks. Topical ketoconazole shampoo can help to reduce the spread of the condition. Of course, not sharing combs and so on will be very important. So the differential diagnosis when you see a scaly patch like that, if it hasn't responded to antifungal, you would want to think, is it some sort of psoriasis or seborrheic dermatitis or something not infectious? Okay, next slide. Thank you. So here we're seeing some red little papules and vesicles on the web space, and what I want you to be aware of is that that there is a burrow on the superior aspect so of their web, right? Can't point out, but anyhow, there's a burrow there. This condition is usually very itchy, and scabies, you just need about 3 to 5 mites to develop the scabies rash or the itching firstly, and the mite tends to gravitate towards the warm areas, so that is under the armpits, in the groin, around the nipple areas. You will get a lot of itching, particularly worse in the night, and when you examine these patients, you will see little papular lesions as well. Okay, next slide. In children or infants, the appearance can look different. It's not the typical appearance like the palms and the soles. This 4-week-old infant male, his mom had scabies and he got it, and you can see his rash is more widespread, papular, almost looking exanthemus. And sometimes they don't necessarily itch, but they are in a lot of distress. And next slide, when we look at the feet and the hands, you can see multiple papular lesions, and sometimes you might see a couple of vesicles there. So that is what scabies can look like in an infant. And the treatment of scabies usually is permethrin first line. You apply it from the neck downwards, wash it off after 12 hours, and then you can repeat the application a week later. If we don't get permethrin, we tend to use skiboma, which is gamma-benzene hexachloride. So you will read potential toxicity of this drug, such as seizures and so on, but we still go ahead and use it in children, and we've been okay. If it's an infant or a baby, rather than leaving it on for 12 hours, you can leave it on for 6 hours. And of course, the whole family will need to be treated at the same time. Okay, benzyl benzoate was also used in the past. Okay, next slide. So the abnormality we're seeing here is that on both great toenails and the toenail on the right second toenail, there is some thickening, some crumbling, some discoloration, some greenish changes on the medial aspect of the right great toenail, and some loss of the cuticle. So this is onychomycosis. Onycho is nail, and mycosis is fungus, right? Onychomycosis. So a nail can take about 3 months to grow out. So if you have to treat the fungus of the nail, you can give the treatment for 3 months, and then you will see growth starting from the proximal nail fold. And that's usually things like oral terbinafine or pulses of oral itraconazole. If the patient's unwell and can't have antifungal therapy because you know they can affect the liver function test, you can use a topical lacquer, but sometimes you might need to use it for 6 to 9 months or even longer. Next slide. So here we're seeing under the second toe this cut, and that is what a fissure looks like. We're seeing a lot of whitish areas of maceration under the toes, and thank you very much for that. Yes, and there is a little bit of scaling and superficial peeling, right? So this is what athlete's foot looks like, or tinea pedis. The more common sites is between the third and the fourth web space. So diabetics, you always want to remind them to examine in between the toes. And you can see with a crack like that, bacteria can get in and you can get cellulitis. And this is why you can get the potential of losing your limb with cellulitis and so on in a background of poor peripheral circulation or a diabetic patient. Next slide. Now on this child, we're seeing some yellow crusted lesions around the nose, on the tip of the nose, and around the mouth. He has these erythematous papilla and this large crusted area on the lower lip. Now, this is the commonest bacterial infection in children. It is impetigo caused by Staph aureus. It is very contagious, and the staph can come from around the nose. All right. And they can form blisters, but the blisters don't really cause any scarring. And to treat, you will use an oral antibiotic such as amoxicillin, augmentin, or flucloxacillin. Next slide. So what if I tell you this gentleman who is in his late 70s has had a crusted lesion on his nose for 6 months. And of course, he's been given antibiotics and it does not work. And the crust falls off, it bleeds, forms again, and with time, the nose is becoming a little bit dented. So this condition is unlikely to be an infection. It's unlikely to be a connective tissue disease. So this is a neoplasm we call a basal cell carcinoma, which is a very mild type of skin cancer. We can see that the patient has very fair skin. Indeed, he is Caucasian and has lived in Trinidad for several years, but is originally from Scotland. And on the nose is an area where he will be exposed to the sun rays vertically, directly downwards. And this type of skin cancer, if we were to leave it, it can slowly, slowly erode deeper into the dermis, into the muscle, and down into the cartilage and bone. In fact, the other name for this type of skin cancer is rodent ulcer. Okay, so this is important to treat, and we were going to treat this. He was treated with removing the lesion, and you can remove it by scraping it off and burning the skin and doing a dual cycle of what we call curettage and cautery, or the patient can be sent for a skin graft. Um, on other forms of skin surgery, such as Mohs surgery, which we don't necessarily have here, but it's useful to be aware of that. Next slide. So this patient also has very pale skin, but he has multiple lesions. And so we see a very large ulcer on the left scapular area. It There are red areas, there are some black areas, some at the superior aspect of it, and this is another rodent ulcer, right? And sometimes if they're a little bit more aggressive, you can get combinations of basal cell carcinoma with squamous cell carcinoma. This is actually a basisquamous carcinoma, and that was removed. But there was some little involvement of the nerve roots, and the skin cancer has come back, and he has been referred to plastic surgeons for further removal. Whenever you're removing skin cancers, you want to take a safety margin ranging from about 3 to 5 millimeters around the edges of the wound. On the right-hand side of his trunk, you will see some of the lesions looking a little bit nodular or cystic. We call them nodulocystic BCC. They are not blisters, and some of them are scaly patches, and superficial ones can look like that. This patient actually is not Caucasian. He's actually black. So we do have to be mindful that we have a small proportion of albino in our population who are just as susceptible to skin cancer. Unfortunately, this young man worked outdoors. He worked in construction and he would spend long hours with his shirt off. After realizing he had so much skin cancer, of course, now he's changed his job and we've excised most of these lesions. Next slide. So to look at some of the other types of lesions to be concerned about in our skin types or darker skin types, apart from the sun exposed areas, you can look at the mouth here on the first left slide. We can see some ill-defined, irregular, actually no, they are well defined, but irregular shape, asymmetrical pigmentation on the upper lip. Next to that is a large exophytic lesion on the fourth toe that is pigmented. You can see that there is loss of the toenail. And next to that, you can see a little bit of discoloration on the small toe, almost looking like fungus, but on closer inspection, we will see pigmentation of the nail fold. And when we see pigmentation of the nail fold, that's a very, very important sign that is called Hutchinson's sign. Underneath, we're seeing on the sole, I would tell you it would be a painless exophytic. It's a nodule. It's greater than 0.5 centimeter coming out of the sole, and this is not a fisheye. You can see again that black pigmentation. Next to that, we will see this ill-defined, really black lesion, and it looks like two spots next to each other. But this is on the face. You can see there's a lot of photo damage. It's an elderly person. And this actually is one lesion. And on the right side of the knee here, on the lateral side of the knee, okay, so just restarting from where I left. Um, so this type of lesion in our skin type, there is a little bit of a different distribution. So it's not all related to sun. For melanoma, it can occur on areas that is not exposed to the sun. So for example, oral genital mucosa, back of the eye, palm, soles, nail folds. Okay, so just to be mindful that this type of skin cancer does exist in our population. Next slide. And you remember that patient I showed you with the BCC on his nose? Well, this is his shoulder, and we can see this lesion here on the shoulder. It does have some grayish black areas, and then it's pale in some areas. So this is actually another melanoma, and the whole lesion needs to be excised. So even though melanoma is not so common population, when we do get it, there is a high mortality rate, and that is because when it's detected, it is detected late, or if it's detected as a nodular melanoma, there's rapid spread. All right, we've had a few patients over the years who do have it, and sometimes they end up having spread to the lung, parts of the liver, and having chemotherapy and interferon and so on. So most importantly for this is being aware of it and also early detection and treatment. Next slide. So here we're seeing a very, very common type of lesions. They're usually on the hands, and these are common viral warts. On the soles, people call them fisheye. So sometimes people mistake melanomas for fisheye and vice versa. And they're actually due to the human papillomavirus. So HPV virus, it's of the same group as that which causes cervical cancer, but it's a different subtype. So if you get vaccinated for cervical cancer, it's not going to protect you from viral warts. And viral warts, they are commonly caused by contact with fomites from the environment. And the wart is like a little person who is actually squatting in somebody's land and nobody knows that they're there and they continue to grow. So all of the wart treatment tend to aim at causing some sort of irritation on the skin so that the body recognizes this foreign organism and mounts an immune reaction. And those treatments can include things like salicylic acid preparations, liquid nitrogen, or freezing treatment, cryotherapy, topical imiquimod, and so on can also be used. Sometimes you can do nothing as well, and they do eventually go away, but that is variable, and the patients can be quite embarrassed about it. Surgical excision is not done firstly because it can have roots that go deeper down into the skin and you can get recurrence. And operating in the hands and so on the palms and soles, you can get damage to tendons and it can be very painful. Next slide. So this is another tumor. This is the commonest type of tumor we see in children. On the left, we see multiple erythematous papular lesions on the trunk, right? And on the right, we see this little girl. She has this red nodular lesion on the cheek, and we can see a little bit of a blush of red areas on her cheek as well. All right. The difference when we compare the right side of her face to the left side of her face in this view, we can see that the eyelid is being pushed up, the nose is being pushed down, and the side of the mouth is being pushed down. So this is a rapidly growing lesion, and the size of the lesion is about twice the actual size of what you're seeing. So it's not the red bit. The red bit is a superficial component. The actual size usually involves the whole cheek there. So that's an infantile hemangioma. And this was one of the first patients that we treated with oral propranolol a few years ago. And she had a really, really good response. And you will treat so that you don't get impairment of functionality. So main thing, functionality, or if it's going to cause significant disfigurement. And you can use that medication for several months. And beta blockers help to reduce vascular endothelial proliferation, and that is why it is effective in hemangiomas. Next slide. So here we see on the left these lovely erythematous, sort of pinkish, well demarcated plaques all on the trunk. And if we look closer, we can see abnormal skin right next to normal skin. Okay, so abnormal and normal skin next to it, we have to think about a condition called psoriasis. So this is your classical textbook picture of a patient with lighter skin type with psoriasis. And on the palms, remember we talked about the psychosocial impact of diseases. You can see the palm is very scaly, it's thickened, it'll be cracked, and will be very painful. So this is psoriasis of the palms, okay? Next slide. Now, in colored skin, it's going to look a little bit different, but you have to be aware that the distribution and the morphology of the plaques are essentially similar. The only thing that's different is really the color. So you're not going to be seeing these salmon pinkish areas. They often look a little bit purplish or grayish. Right, and so when you come and you ask you, please don't tell me that you're seeing pink or salmon when it is on there. Right, so here if we look closely, we will be seeing well demarcated scaly plaques. Right, distribution is the same, particularly at the lower back there. Next slide. So psoriasis can commonly affect the nails. It can cause coarse pitting, so pitting, which are little dents on the surface of the nail. So, for example, you can get psoriasis of the nail fold causing that, or in the absence of psoriasis of the nail fold causing the pits. You can get onycholysis, which if it happens distally, you can get separation of the nail plate from the nail bed. If it happens within the nail bed, we call that an oil drop sign. You can get some psoriasis developing under the nail fold. We call that subungual hyperkeratosis. Nail psoriasis can often be associated with other manifestations of psoriasis. Next slide. So in this lovely picture here, we're seeing, in addition to the changes in the nails, we are seeing changes in the joints, almost like rheumatoid changes. Okay, so we're seeing some Z-Tom Boutonniere deformity. So rheumatoid changes in a patient with psoriasis. And that tells us something important, that psoriasis can be associated with the joints. In fact, about 25% of patients with psoriasis will have psoriatic arthropathy, commonly called, affecting the small digits of the hands, but can affect any other joint actually. It can present as a monoarthritis or polyarthritis, sacroiliitis, or problems with the cervical spine. In its severe form, it can also result in arthritis mutilans. Next slide. Just to mention, treatment for psoriasis, in addition to topical corticosteroid, you will use vitamin D analogs. You can use phototherapy, calcineurin inhibitors, and some systemic treatment include methotrexate, cyclosporin, and biologic drugs. So this slide, I would like you to be aware that it is actually representing the same disease process. So where we see the knee on the left-hand side, at the back of the knee, on the knee flexors, we're seeing some whitish scaling, ill-defined areas, and on the knee extensors, a similar process, and we're seeing exaggerated skin markings because the patient has the stratum corneum has responded by becoming thicker. And this we call lichenification. Lichenification. So commonly you would see this in eczema. Okay, so we see eczema occurring both on the flexure and the extensor. On the same patient, you can also have eczema having a different appearance. On the right-hand side on the neck, we're seeing a large patch. Sometimes it will look erythematous, sometimes it might have a more grayish or purplish hue and darker skin type. But again, it's usually ill-defined as opposed to psoriasis, which is well demarcated. Next slide. And so we see this little baby here. The abnormality is that his skin has this somewhat reddish, pinkish hue. It is swollen and it's inflamed and flaky all over, and he's miserable. He's scratching it. And when we see skin like that, we call it erythroderma. So the skin is inflamed, red, swollen, peeling, involving more than 90% of the body surface area. And if we think back about our physiology of the skin, one of the main functions is to reduce transepidermal water loss, to reduce loss of protein as a major protective barrier from viruses, bacteria, and other infections and trauma of the skin. So if the skin is inflamed, the patient can become dehydrated. An older patient, it can push them into cardiac failure or renal failure. So a patient like this, you would want to admit them to hospital, use what we call paraffin wraps with topical corticosteroids to calm down, cause that initial vasoconstriction, and reduce the inflammation of the skin. Next slide. So another appearance of eczema on the top left, we're seeing some papular lesions on the chest, and sometimes the papules are so fine as in the bottom right, they look a little bit more follicular, and we call this papular and follicular eczema. So in one patient, you can have different cutaneous manifestations of eczema. Okay, next slide. And here, eczema on the back of the neck here, looking a bit gray. And on the dorsum of the hands, not looking too different from psoriasis. Sometimes it is difficult to distinguish eczema from psoriasis on the palms and the soles, and you would have to look elsewhere for other signs of that particular skin disease. We rarely do skin biopsies to diagnose eczema and psoriasis, as they're more clinical diagnoses. Okay, and you can see where this condition can cause a lot of psychosocial impact as well. To summarize some of the treatment options for eczema, apart from topical corticosteroids, as we talked about before, antibiotics if the areas of cracked skin. Systemically, we can use short courses of oral corticosteroids. We can use other immunosuppressants, for example, azathioprine, cyclosporin, methotrexate in older age group, mycophenolate mofetil. Phototherapy can be used for both eczema and psoriasis. Calcineurin inhibitors like Elidel or Protopic, which is pimecrolimus or tacrolimus, can be used on areas like the groin or the eye where you want to have less damage by topical corticosteroids. Okay, next slide. And so this type of dermatitis is probably the commonest type of dermatitis that we see in our population. And similar to all Caribbean populations, it is called seborrheic dermatitis. So even though its dermatitis is not associated with the asthma and the hay fever and the allergic rhinitis that you can get with atopic dermatitis that often starts in childhood, this one is different in that you get scaling around the nose, you can get scaling in the ears, the nasolabial area, eyebrows, and you can get dandruff. Sometimes it can occur in the central chest and creases, like in the axilla or the groin. In children and babies, you can get hypopigmented patches that are usually not itchy, and you don't get that sense of dryness of the skin as you would get in a child with eczema. And seborrheic dermatitis, you can get like a secondary yeast phenomenon that occurs, a yeast infection phenomenon. So to treat this, apart from regularly moisturizing the skin, you can use a topical corticosteroid, a topical anti-inflammatory drug, and use combinations of a topical antifungal. So next slide. So this is another common disease. In fact, it is the commonest skin disease we will see in the adolescent population. It is called acne. And on the top left-hand side, we're seeing the more papular pustular variant. We can see it's close to the hairline. So in a patient like this, you would want to ask them about the hair products. And on the right-hand side, we see more nodules and cysts and so on the cheek. Now, this nodulocystic variant of acne is more severe. So acne generally is classified as mild, moderate, severe. So when it's severe, with nodular cysts, mild is papules, pustules, comedones, and moderate is papules, pustules, etc. But not as severe as the comedones, as the cysts, which have an increased risk of causing scarring, because scarring is very difficult to reverse. So you do want to treat it. The milder variant of acne that contributes to hyperpigmentation, mainly you can treat retinoids, topical benzoyl peroxide, and when it becomes more moderate, you can use those two things, topical antibiotics as well for the mild, oral antibiotics for the anti-inflammatory, antibacterial properties. When those don't work, you will use oral retinoids, and the retinoids have an effect on the sebaceous gland, so they reduce the sebum that's produced, which we know is an important factor that contributes to the proliferation of the bacteria, which is Propionobacter acnes. Okay, and oral retinoids such as Roaccutane or isotretinoin are usually given for like about 4-month intervals. Okay, next slide. So this patient is older. So whereas acne is more common in the adolescent or younger age group, this type of rash can look like acne with the inflammatory papules and pustules, but the distribution is a little bit different. So you will see them in the central convexities of the face, so in the central forehead, the cheek, on the nose area, And this is called rosacea. Next slide. And on the cheek, you can see a somewhat confluent repeated flush that can be associated with rosacea. Sometimes a patient might have both rosacea and acne, so it's important to uh, bear this in mind because treatment for both conditions are similar, but the duration of treatment is a little bit different. So here you can use topical retinoid or topical metronidazole. Um, it is also thought that the mite mite can be associated with rosacea. It isn't always like that because there are different types of rosacea. So just on a mild note, the person we know who has rosacea, most popular, is Santa Claus because he always has lovely red cheeks and he's in the cold. But that's just aside, we do get rosacea in our population too. So we might not see the redness, but we see that those papular lesions on the face and so on. And as opposed to acne, it tends to not occur in the trunk and the shoulders. All right, so this is easily treated with a short course of oral antibiotics such as tetracyclines. Next slide. And this little boy here, you can see that depigmentation on the right lower lid. It is well demarcated, complete loss of pigment. And you can see some edges are a little bit irregular. And he actually has vitiligo, and he's used a mild topical corticosteroid such as hydrocortisone. And of course, you don't really want to give him something stronger. So we then gave him the calcineurin inhibitor, pimecrolimus, and he did have a really good response. So he was happy with that. Vitiligo patients, it's important that they do have realistic outcomes of their disease because there is no cure for it. The treatment does not necessarily work 100%, and then you can use other cosmetic things like cosmetic camouflage to, if there is concern and if there is significant psychological impact. Other than that, if the patient is happy and is accepting of their disease, then it's fine. There is no need to treat. As it doesn't affect you internally, can be associated with other autoimmune disease, because this is where the body is fighting against the melanocytes that produces pigments so other autoimmune disease like diabetes and thyroid, we don't necessarily go looking for this for. Next slide. So this lady has a bilateral, almost symmetrical hyperpigmentation of her cheek. And this is called melasma or chloasma, which is due to deposition of pigment in the epidermis, sometimes going down into the dermis, thought to be related to pregnancy or use of the oral contraceptive pill. But we do know it's more common in darker skin types, and men get it as well. To treat this, you can use bleaching products, sunscreen, as well as cosmetic camouflage. Next slide. So this young lady on the top left-hand portion of the slide, you will see some erythematous, somewhat scarred areas around the cheek. And on the lower right, we see this somewhat annular-looking plaque on the jawline of this gentleman with a pinkish center. And this is called discoid lupus, which is a scarring type of skin disease that occurs in the sun-exposed areas. Now, discoid lupus can occur independently of systemic lupus. In fact, only a small proportion of patients with discoid lupus actually ever go on to develop systemic lupus, but it is one of the cutaneous manifestations of them. So to treat, apart from topical corticosteroids and sunscreen, sometimes you will need to use oral anti-inflammatory, anti-malarial drugs, etc. Next slide. Now, systemic lupus is more common in women than men. In fact, 1 in 10 women can have a false positive antinuclear antibody. Now, this is the more typical malar rash on the cheek. We've seen it on the cheek and a little bit on the nose. So it's erythematous, scaly. For this type of patient, you would look inside of the mouth for oral ulceration. You can look in the ears for areas of discoid lupus, or you're going to look for other cutaneous changes on the skin you can see with systemic lupus, such as annular rashes, as in subacute cutaneous lupus. You can see vasculitis, erythema multiforme, erythema nodosum, etc. So systemic lupus typically with the malar rash. Okay, you can also get a rash in the cheeks in patients with mitral stenosis. You get that telangiectasia as well. So next slide. Just to remind you, the difference between the malar rash and seborrheic dermatitis is that seborrheic dermatitis involves the alar crease, whereas the malar rash doesn't. And sometimes patients with lupus will also have seborrheic dermatitis. Now, this little elderly lady here, she's actually in her 80s, presented with itching on the lower legs and developed these blisters. And if we look closer on the lower right, we're seeing a hemorrhagic blister there. Hemorrhagic blister, it has fluid and it has blood. So hemorrhagic means that the blood must be coming from somewhere. So the blood can only come from the dermis because that's where we have our blood vessels or capillaries. So that defect for this condition would be at the basement membrane zone. So here you get antibodies against the basement membrane zone that attaches the epidermis to the dermis, right? You get compromise of the basement membrane zone and leakage of fluid as well as blood from the dermis. And this is bullous pemphigoid. So remember, it ends with D, and D is a deep blister. So it's at the basement membrane zone, as opposed to the next condition, next slide, where we see flaccid blisters. Actually, you see those two eroded areas, and there's some flaccid blisters. Yeah, those are the flaccid blisters. So they pop very easily, and sometimes the patient might not even notice blisters there. And this is a condition called pemphigus vulgaris. And the defect or the abnormality is the patient is producing antibodies against the intraepidermal keratinocytes, desmoglein 1 and 3, which actually hold the keratinocytes together. So with this condition, it is a lot more serious than bullous pemphigoid because the patients can have the condition for longer, and they often require larger doses of corticosteroids and immunosuppressants, and these are associated with risks of infection and so sepsis and so on. Next slide. So here on the left, we're seeing this gentleman, and around the neck, he has a lot of little fine polypoid lesions, which we call skin tags. And on the right, he has had them removed, and this is something you can do in your primary care office. And this is, you can simply snip them off and cauterize the base. Now, skin tags tend to be more common in people who are overweight, who have a tendency for insulin resistance, diabetes, PCOS. You can also get them under the arms and in the axilla. On the face, we can see sometimes little warty lesions that are not skin tags, and they're not moles. They're actually called dermatosis papulosa nigra. And commonly, Mr. Morgan Freeman has a lot of them, but we do have them in our population. We all get them with time, and they don't develop into skin cancer. And they are called dermatosis papulosa nigra. Okay, and they can be treated the same way by simply cauterizing them in your office. Next slide. So that's the end of this presentation. There is some reading material for you. You can look at these websites for more information. And if you have any questions, let me know. Okay, thank you very much.
Thanks, Namala. It appears the students don't have any questions, and I'm glad we were able to still carry on the lecture in spite of the technological challenges. All right, students, so I'll try and post the recording later on. So for those of you who want to review it or haven't been able to attend this morning or miss part of it, know that we assigned some more forums last night. Some of you would have gotten dermatology type cases, so hopefully the lecture will help you respond to your forum. Okay, the next set of live lectures will be on Thursday morning with Dr. Sunarain, and then in the afternoon with Dr. Mohammed. So I guess we may see you guys then. And if Dr. Mohammed sends something in preparation for his session with you all on Thursday afternoon, I'll post it on my learning.